Happy Friday, everybody. Another Q&A Friday here for you with Teresa Regester, the home health mentor. I'm Amy Regester, her adoring daughter, and today we are doing another part in the series on marketing because, as we were talking about before we clicked the go live button, we are so thankful for those of you who wake up every morning wanting to serve your community in a high level type of way. And we want to make sure that you're getting return on your investment when you go to either scrounge up your own referrals, just hitting the pavement, or you're paying dollars for them. We want you to be able to pick ones that are right for you and will make you your dollars back. That's going to keep you in business. So all right, we've got my mom today with a giant list. I saw it earlier, but she promises that it's going to go pretty quickly. So, hey, good morning, Mom. Tell us what we need to know about getting a good referral.
Yeah, good morning. So we've been talking the last couple times about marketing, and all of that is good information. But when it is all boiled down, the important thing is whether or not all of that effort, all of that work, all of the money that you spend on marketing, the important part is how many of those efforts pay off in an admission to your agency. So none of that does any good unless you actually are able to admit some patients from your efforts. So the first thing I wanted to hit on, and I probably don't really need to say this, but I'm going to. You want to make sure that your processes are legal. There are some legalities involved in getting referrals. So you're not supposed to solicit, you're not supposed to be self-serving, you're not supposed to misrepresent your agency. You're supposed to be working with physicians who are ethical and giving you appropriate referrals. All of that, comes under the heading of maybe legal and ethical considerations. So like I said, I probably don't really need to bring that up, but I will tell you that I have seen organizations that did not meet that initial standard.
I want
And
to talk smack about them. Don't just go on like that's nothing. Like, can we
well,
know
it
what?
is a big deal,
Yeah,
obviously.
I think like there's some things that are obvious, like don't be bribing individuals to be like, hey, give us all your referrals no matter what. But are there any things that are kind of borderline that you might not even think are like super scandalous, or you might just think, oh, this is what being friends with our neighborhood, hospital administrators looks like, and it's just inappropriate or something?
Well, there are hidden perks that some agencies, build into their relationships with referral sources, and things like free tickets to a concert or something like a free weekend at a hotel, or there's all these little things that people could think are just maybe thank yous for referring patients to you. Those are still very inappropriate, even if you're doing it for the right reasons. So those might be, things that you might think are in a kind of gray area. It's not a gray area. It's really black and white. You can't do that.
So that one seems obvious because of the dollar amount to me, like if you're sending somebody to that. But what if you just hosted like a community luncheon for all your physicians? Is that borderline, or is that an okay one?
Well, the question is, why are you holding a luncheon, and are you providing something of value to the physicians that would help them understand the services for their patients? So if it's educational, truly educational, absolutely. One of the things that our agency used to do is host a table at the hospital cafeteria, and we were hospital based. So, you probably couldn't do this. Most agencies couldn't do this, but we hosted a table at lunchtime at the hospital, we would take all kinds of information about their patients in our files, and we could give our physicians updates. And we would have a dessert there for the doctors who wanted to come and get an update on their patients. So technically, we were giving them free dessert, but it was an opportunity to meet face to face with them, to answer their questions, to maybe give updates about what was happening with their patients. So that kind of thing, I don't I don't think agencies, especially hospital-based agencies, I don't think they would run into problems with something like that.
Sure.
Marketers also take lunch to doctors' office staff and to physician groups, but they're doing some kind of an educational program while they're providing the food.
All right. So if it's educational and you can legitimately look at the dollar expense and not think this looks fishy, those are probably just good rules of thumb. And then if it's like a big booze cruise or something like that, you're going to get checked real fast. So anything in between, consult your local laws.
Yeah. I mean, again, you have to think of it from the standpoint of ethics. Is whatever you're doing something that you're doing just to gain favor with a certain group of physicians so that they'll only refer to you? Or is it something that you're providing some kind of an educational program or a service to them while you're doing whatever you're doing? So,
okay.
Yeah.
All right.
If it's big enough that it's going to be coercive, then you're in trouble.
All right. I mean, I can be coerced for a donut. So I just thought we've already spent too much time on this, but I just wanted to kind of air it out in case people were afraid that their luncheons would be under suspect. But I don't think that's the case. All right. What's on there? What's on your list?
Okay. So so there's some things that you want to be aware of as far as legalities. Obviously, CMS has some regulations about what you can do to get referrals. And I'm not going to go into all those details because you can go to the cms.gov site and do a search on that. You also should do a search on the physician self-referral law, which is also known as the Stark Law. If you're not familiar with it, it has been updated and changed. I think that went into effect in either later 2020 or early 2021. So there have been some updates to that law. If you're not familiar with it, you can go look it up. And I did put a link in my page to you, Amy, if you would be able to put that on my site. Sure. That would be maybe helpful for somebody.
Okay, I'll put in the description once we're done, and I'll put it in the comments right now.
Okay, good. So when you're trying to prepare a referral for your organization, I kind of look at it like the process is a puzzle. And if you've ever put a puzzle together and you've gotten near the end of the pieces and you see there's more blanks than there are pieces to fill those blanks, you start to get a little nervous. And so the intake process, or the process of getting the information together for a referral, is kind of like that. You're going to fill in the pieces that you know, and you're going to do as much of that picture as you can build for whoever's going to be making the first visit to that patient. Mm-hmm. And there are some preliminary things that you want to make sure that you take care of, because if you don't do a good job, there are some problems that are going to come up later. So the point is, make your process as thorough as possible, because if you don't, there's three things that can happen that are very uncomfortable. First of all, it can slow your intake process down. It can even delay the admission of a patient that's in the hospital because maybe there's information that you don't have and you can't get in a timely manner, and it can make the patient stay in the hospital longer. So that's more costly to the patient and to whoever's paying for their stay. The second thing is that it makes your admission nurse go into the patient's home blind. They don't have all the information they need. And that comes across as your staff not knowing what they're doing. It undermines the patient's confidence in your agency and could affect their longer term perception of your care. And we've talked about star ratings. This is where your star ratings kind of begin. How you handle that admission process is really important from the standpoint of the patient's confidence. And then thirdly, it creates cash flow issues because you cannot bill until all of the documents are in place, completed, and signed by the appropriate providers. So those are the problems if you don't do a good job getting your information together.
Okay.
So yeah, there's some very basic things that you need to make sure you get when you're trying to get a good referral. The first question is the patient going to be in your service area? And even though patients are usually only referred from a local hospital, you don't necessarily know that the patient at the time of discharge is going to go back to their home. Sometimes they're going to stay with a relative that is outside of your service area. So you want to make sure that the question is, where will you be discharged to? Where will the patient be going home to?
That's great.
Going to a next level facility? Will they be going to stay with a daughter, son, someplace else out of your service area? If that's the case, obviously you're not going to take that referral. And it's a question that we sometimes forget to ask, and it sometimes it's on a borderline, and you think that the patient might be in your service area, and then you find out they're not. So it's important to know the exact address where that patient's going to be discharged to.
Right, not just their home address. Got it.
Yes. And we sometimes make that the assumption, and it's not always the right assumption. Secondly, you need to know who is going to be paying for the home health services. If the patient is a Medicare, a traditional Medicare patient, we're very familiar with those regulations, and we know, fairly quickly if that patient's going to be homebound, if there's a physician that's going to sign the orders and oversee their care, and they're meeting the basic requirements, we're good to go. If the patient has some other type of a Medicare supplement or alternate type of, Medicare, any of the, Humana or United Healthcare, they have their own brand of Medicare type services. There may be some special things that the home health agency intake staff need to know about, what kind of coverage is included in that. So that sometimes has to be researched a little bit. And if the patient has other types of insurance, they definitely need to know what kind of insurance is going to be covering it. And if there's some type of copay, that's the time the agency would need to notify the patient of what their copay and their portion of the cost would be. So those are all things that happen really upfront, the very first things.
It's kind of an awkward first date, So
well, a lot of that we can get from the patient's chart in a facility, and that usually comes from a case manager or someone who is doing the discharge planning. So it's not always, something that you're talking directly to the patient about.
Also, I forgot to ask, but who is figuring this out? Who in the agency? Like, I know that especially in a smaller agency, people wearing multiple hats, but what would
it would
yeah.
normally be an intake person,
Okay.
and that different agencies do it differently. Some agencies have someone who does the initial non-medical kind of screening of patients. But
Okay.
in every agency where I have worked, we have a nurse do that process. And that's because we don't want to have someone else do the screening and then have someone else, have to ask some other questions that kind of hinge on that initial information.
Okay.
So we just find it best to have an intake nurse who works with whoever is giving the referral. We have specific people who are designated to take those referrals. And if it's a patient that's going to be getting nursing services, then our nurse handles the whole process. If there's going to be therapy services involved, then there may be some conversation between the intake nurse and our therapists who are likely to be providing those services.
Okay. That's helpful.
Yeah. So most agencies have designated case managers or an intake person who is trained specifically to do that. Is that good? You got it?
Oh yeah.
Okay. So there's a few questions that you will want to answer next and some information that you'll want to gather. So the next one that I would say is going to be important is, what's the anticipated date of discharge if the patient's in a facility? You want to make sure that that you are not surprised by the discharge plan. So if someone calls and wants to make a referral, you definitely want to know what's the anticipated date of discharge. And then as an agency, you want to make sure you have the staff available to do that admission.
Mm-hmm.
If you can't do the admission on the day the patient needs it, it is not appropriate to ask the doctor to change the date of discharge. Now, if the physician gives you a specific date for admitting the patient, and that would happen, for example, if the patient is having some type of antibiotic infusion, you can't wait on those kinds of patients. When that patient is transferred home, they usually have to have an infusion within a few hours, another, antibiotic infusion. So it's not like you can change some of the days around, but you do have 48 hours that you can, up to 48 hours, you have some leeway unless the doctor has specified that you have to admit on a certain day. And it's usually 48 hours from the time of the referral, or from the time the patient is discharged, or on the day the physician has ordered the start of care. So as an intake person, you have to know that. You have to know which one of those is going to apply. So you have to know what's the plan here. When is this patient going to come home, and when do we need to line up a nurse to do the admission?
So it's a great fit for you if you can seamlessly transition that care. But if there's even going to be a few hours outside of what's needed, especially on those critical things, that's just not a good match for you. Going to have to pass.
Right. And you want to let your referral source know as soon as possible. If you're not going to be able to take that referral, you want them to know so they can begin the process with a different agency.
Mm-hmm.
Okay, so there's all the patient demographics, and I'm not going to go into a lot of detail on that, just age and gender, all that kind of stuff. You're going to fill out in your intake form, and that might be on paper or it might be electronic in a electronic chart. You're going to want to get medical records information, which will include a signed H&P, which is history and physical. And if the patient's coming from a facility, you want a discharge summary from that facility, and that will include a medication list. And any new medications, you want to ask if they've been ordered already, if the patient's got some samples to take home. That, sometimes the hospital pharmacy will give the patient some medications to get them through the first few days, so they don't have to go pick up a prescription immediately. But you need to know that. And then the other question that a lot of times we don't ask is, can the patient afford the medications that have been ordered? It does no good for the patient to have prescriptions but not be able to afford the medications. So sometimes it takes some time to find a way to get the medications that patient's going to need. We also are going to ask for visit notes from any providers that the patient has seen, and that would maybe come from a physician group if the patient is being referred directly from physicians' offices. Then we want some history and background about the patient. We would contact the primary care physician to get their verbal permission to admit a patient if we don't have a written referral from a hospital or a facility of some kind. We would want to make sure that we get at least the verbal order from whoever the physician's going to be that's going to follow the patient. And we can, at that same time, get their demographic information, insurance information, and, the patient's, the details about where that patient's going to be. A lot of times, patients will go and stay with relatives. So all of that, again, we need to make sure we know where that patient's going to be.
So this, just let me butt in here, because we've kind of skipped from how to get a good referral to actually how to make the transition with the referral. But I'm still stuck trying to figure out, are we measuring if this referral is still a good fit for us when we're doing this? Or are you just assuming that this is good now and we're going forward with the information that needs to be collected?
So we've determined that the patient is a good patient for us. What we're talking about now is what kind of information makes this a good referral. So the patient's appropriate, but
so
our referral,
this is moving from marketing now to intake?
Yes.
Okay.
And
just
making sure that all of the work that you've put into getting this patient on board, that when someone is ready to do an admission, that we have all the information. So a good referral doesn't just mean that the patient's appropriate. A good referral means that we've got all of the information that we need about that patient to do an admission.
Okay. And that's where our agencies make their marketing money back. Yes. Is by making sure all these boxes are checked.
Yes, because again, if they're not, we kind of go back to where I started, where I said, these are the problems. If you don't do your job up front, then it takes, time to get the patient admitted, and the nurse is going in blind, and you have cash flow issues. So
makes sense now.
A good referral is a good patient, as well as good information about the patient to allow you to expedite the process of getting them transferred into your agency. So yeah, you want to, get all of the demographic information. The other thing you want to do is make sure that the patient has had a face-to-face encounter with the physician and that you know what you're admitting the patient for to home health. And what I mean by that is when a patient's gone to the hospital, sometimes they go into the hospital for one reason, whatever that reason is. But when they come home to home health, maybe you're not going to be dealing with that part of their diagnosis at all. Maybe there's something else that you're going to be doing for home health. So which diagnosis will you be treating in home health? And that becomes the basis of your plan of care. So you can't just assume that the diagnosis that someone had on their paperwork in the hospital is the same thing that you're going to be focused on in the home health agency. So your intake staff need to understand that. And we have to make sure that whatever we're going to be doing in the home health arena, that we have staff who are qualified to care for a patient with that particular issue. And again, that's sometimes something that we don't understand at the time the referral is being made. You may have a patient who went into the hospital for some type of cardiac procedure, and when they come home, maybe the primary focus is going to be on therapy. So you have to understand what's going on with the patient and what the home health agency is being asked to do. You won't necessarily address everything that was going on in the hospital. Mm-hmm. We're now looking at what's appropriate for home care. If the patient has been referred from the community, then we definitely need to know who the patient's physician is so that we can get verbal approval to do an assessment of that patient and whether or not they're appropriate for home care. Mm-hmm. And we also need to know when their most recent visit was with the physician, because there's a specific time frame in which the patient had to have been seen by the physician. And the physician has to have seen them for the kind of problem that they're being referred for. If not, then we need to set up another appointment for that patient to go back and see their physician so that we can get appropriate orders. Another thing that we haven't always had to deal with, and we sometimes forget, is we need to find out if the patient has a legal representative. In recent years, we have had to make sure that if we're doing an initial visit, and sometimes we're going to do some care at the same time we do an initial assessment, the patient's representative, their legal representative, has to be included in that process. And we have to give appropriate information to both the patient and the legal representative before care can be provided to the patient. So part of the intake process to make sure that we're not wasting time and we've got the right people there is to ask whether or not the patient has a legal representative that needs to be included at the time of that first visit. We also need to know if this patient needs any special equipment, and if so, who will be providing it or picking it up or delivering it, and how and when will it be delivered to the home. We don't want a patient who is post-surgical for a knee surgery, for example, to get home and there won't be a CPM machine there. If the patient needs a certain kind of equipment, all of that needs to be taken care of before the patient's discharged. or there has to be a plan, and the timeliness of getting that equipment to the home is really important. Some of it is not so critical, but usually if a patient is homebound, there will be certain equipment that if they don't already have in the home, they will need to have delivered to the home, or someone can pick it up maybe from a medical equipment company, but it needs to be available to the patient right away. Sometimes patients are discharged late in the day, and as we all know, Fridays are the day the hospital's trying to empty the hospital. So if patients are discharged late and some of these things are not taken care of, you can imagine the kind of challenges that families would have over the weekend before they can get the stuff they need, either medications or equipment. And even, making sure that the admission can take place when the patient needs it. So all of these things are, part of making sure that not only is the patient appropriate for home health, but do we have all of the information that we need, and have we tied up all the loose ends so that the transition for the patient and the family happens smoothly. So that, I guess, I don't really have any other, anything else on my list that I think we would need to cover, but I would be happy if somebody has any questions or comments. I'd love to see them on my page.
Yeah, that's the best way to get Teresa's ear is by going to the Facebook page, The Home Health Mentor, facebook.com/The Home Health Mentor, and sending her a private message. That way we know what we can cover for you. And particularly if there's a topic that we've already done that we want to come back and give more information to you, that's kind of top of our list. But any questions are welcome. And Mama, what are we going to do next week?
I don't know yet. I haven't decided yet.
All right. Do you want to?
I would love for people to tell me what they want to know. I've been toying with, kind of taking a sidestep and talking about COVID treatment of patients in the home and some of the challenges with COVID. I just don't know whether or not people are still in the dark about that, or if they feel like they've been inundated with information on COVID. So I guess, again, I'd love to hear, what people are feeling a need for.
All right. Well, we will continue to put that out there. And then I also wanted to ask you what you're working on now, what products you're working on to be released on the website shortly.
Well, one of the things that we've talked about is the contractor handbook, and maybe I can explain a little bit about it. One of the requirements that CMS has and your accrediting organizations will require is for you to document that you have oriented your contractors to your agency's policies and procedures. And I will tell you, from a surveyor standpoint, that was one of the weakest parts of the agency's surveys that I saw time after time. So I decided that maybe there was a need out there for a contractor's handbook that goes through much of the same kind of information that you would do for an employee, but also include the specifics that are required under CMS and accrediting organizations that you, in addition, make sure that you cover with contractors. And the information that you need to keep in your agency on a contractor is different than what you would need to keep on an employee. So there's some things that are different about the contractor's handbook, different than your employee handbook. So that's one of the things that should be available shortly.
Yay. We don't want you to be weak. We want that to be a strong area for you and your team. So yeah,
Absolutely.
we'll get on there. I've got a little note here from Andrea Owen Shearer who says supplies, issues with getting timely physicians to sign, staff follow-up. So that might make more sense to you than me. Andrea, was that in regards to marketing? Oh, that's just general, huh? Supplies.
Read that to me again.
Supplies, and then issues with getting timely physicians to sign, staff follow-up. So I think those are 3 separate suggestions.
Yes.
And Andrea, we know you're probably typing this in on your phone. It's not that you don't know how to write whole sentences. It's just poor
I'm
thing. You're
guessing.
like doing 3 other things and
Well,
trying to type in there.
she brings up something that is an age-old problem, which is getting physicians to sign their orders. So I'm guessing that that's what she's talking about.
Yeah, she says discharge orders. Who is following?
Okay, from a hospital discharge. Oh yes, we've had that problem forever, and it's gotten better, I think, since a lot of hospitals now have a hospitalist on staff, and a lot of times they're the ones that we've trained to give us the transfer information, and we then find out, who that information is being handed off to, which physician in the community is going to follow that patient once the patient's home. So I'm pretty sure that's what she's talking about. And it, that'd be something good to cover.
Can we do a whole podcast on that? Get some stories from the field?
Oh, yes. Okay. Oh, yes. Yeah.
All right. Well,
so thank you for those suggestions. We'll consider all of those and see what I can put together that might be helpful. Some little tricks.
Yeah. All right. Thank you, Andrea. And because you participated today, I definitely want to send you a coupon code for 20% off some of the stuff that we've got going on in our store, hoping that will be helpful to you. So if you want to send my mama your address, I see you're watching from Facebook, just send in a private message, of course, because we don't want everyone spamming you. Your email address, I would like to send you a coupon. All right. That's about it for us today. And I'll be traveling next week. So I don't know if we'll get in a Q&A Friday with me next week, but maybe Mom, you'll want to do one on your own or have a guest in. But either way, we'll see you real soon. And thank you so much for hanging out with us today. Bye for now.
Bye.